To take out the kidney or to save the kidney? That is the question asked by one of my Facebook followers. In this video, I'm going to answer the question she asked, which raises more questions for me than anything else. This is also why physicians can't appropriately or adequately answer questions on any social media forum, because we never have all the information we need and we can't give an adequate or complete answer. My name is John Lin. In addition to being a urologist and the #1 vasectomist by volume in Arizona, having performed about 2,300 vasectomies in the last couple of years alone, I'm also a small-time YouTuber and a Facebook influencer with several thousand followers. As such, anytime you put out content on the internet, you're bound to get questions. The person who DM'd me, who shall remain nameless, is not my patient. And the advice I'm about to give today should not be construed as medical advice, as I'm not her doctor. And the question goes something like this. Dr. Lin, hi, it's so-and-so. I'm so upset right now. My CAT scan of the abdomen and pelvis today showed the left ureter completely blocked from radiation due to cervical cancer, and the left atrophic kidney is filled with urine. The MD gave me 3 choices. Number 1, a nephrostomy tube. Number 2, nephrectomy. Or number 3, reconstructive surgery of the blocked ureter and attachment to another portion of the bladder. Is there a 4th option? What would you suggest? I'm sorry to bother you, but I'm devastated. All right. As usual, just like anything else, when you ask these questions on the internet, I need more information, and I'm a little bit more confused because here's the situation. It seems like she has been diagnosed with cancer of the cervix, which is a part of the uterus, and she received radiation to treat and try to cure this cancer. Well, guess what? The cervix and the uterus are right down in the pelvic area. And that pelvic area, when you hit it with radiation, the stuff around the area that you want to treat is also affected. Sometimes that area involves the ureters, which are the drainage tubes from the kidneys going down into the bladder, or sometimes the bladder or the rectum. It's all in the same area. Similarly, when we treat prostate cancer with radiation, the rectum is sometimes involved, the bladder is sometimes involved, in addition to destroying the cancer that is in the prostate. So I digress. In her case, it sounds like she had cervical cancer that was treated with radiation, and now one of her ureters, the left ureter, apparently it sounds like it's blocked. And also, when she said that fluid is filling up in the kidney, that tells me that this is maybe hydronephrosis, meaning urine backing up into the left kidney. She said left atrophic kidney is filled with urine. So I'm assuming that this is hydronephrosis, and as you know, assuming has risks. So let's just say that her left ureter, the drainage tube from the left kidney, has been blocked, or some sort of fibrosis or blockage took place after radiation, which is causing backup of urine into the kidney. You see, kidneys are constantly making urine, and when you block the ureter, it's kind of like a ureteral stone, or in this case, a fibrosis or some mechanism which caused blockage of the ureter, it causes backup of urine into the kidney, and that backup can be very painful. And it's the reason why people have horrible pain from kidney stones is due to that back pressure. So she's telling me that her left atrophic kidney is filled with urine. So that phrase has a lot of information and implications. It tells me that the ureter is blocked. It tells me that the urine is backing up into the kidney. In addition, she said atrophic kidney, which tells me that the kidney is shriveled up. Atrophy means shriveling, the shrinkage of the kidney. So kidneys shrink when you cause constant back pressure into the kidney, and body is just amazing. The body automatically, whenever the kidney feels an increase in hydrostatic pressure, meaning more fluid pressure into the kidney, it automatically regulates the blood flow by decreasing blood flow to the kidney. So when you cut blood flow to the kidney over time, it shrinks, it shrivels up. And that's why urologists intervene very soon when someone comes in with an obstructing stone in the ureter, meaning a stone that is blocking the drainage of the kidney. We want to take care of that so the kidney doesn't shrivel up over time. It seems like this has been going on for a while. She's telling me that the left kidney is atrophic. So it's shriveled up. So my question is, how shriveled up? Is it so shriveled up that it no longer has any significant function to that kidney? Because the treatment options being discussed with the patient will vary depending on how much function is left in the kidney. If there's very little function and it's not causing any pain, well, then why even bother? Why even mess with it? It's not working. It is not draining well, but it's not causing any infection or pain, bleeding. So why even do anything to it? Why even do a nephrostomy tube? Right? Why even do any sort of reconstruction if there's not much function in that kidney? So nephrostomy tube is placed through the back directly into the drainage area of the kidney to try to drain that kidney, to maintain the function of the kidney, to decrease the risk of infection. That's why you want to put in a nephrostomy tube. If the urine is not going to be able to go downstream, you try to drain it upstream from the back directly from the kidney. You put a tube by the interventional radiologist is typically the one putting in a tube through the patient's back flank area to drain that kidney. In this case, it will be her left kidney. So option number one would be a nephrostomy tube. That would be an ideal situation if you don't want to have big surgery to try to reroute the ureter and you want to maintain function of the kidney, or if you're having infection due to obstruction. But if the kidney is not working well, then you can probably just let it burn out, meaning it's already not doing much work. The right kidney, presumably, is doing more work. And over time, that right kidney, if you were to get an ultrasound or a CT scan or some sort of imaging, that right kidney is going to compensate for the shriveling or decreased function of the left kidney. So that kidney on the right side growing larger is called compensatory hypertrophy. On imaging, the right kidney is going to be bigger than the left kidney. If the left kidney has good function or some adequate function, it's probably not going to be atrophic. If it is atrophic, then why even bother putting a drainage tube unless the patient's having symptoms? So nephrostomy tube, maybe, if indicated. Option number two mentioned was nephrectomy. Nephrectomy is surgical removal of the kidney. Now, that will be indicated if the kidney is no longer functioning, is causing symptoms, and it does more harm than good by leaving it in. That is when you would want to have it taken out. And typically that is done with laparoscopic approach or robotic assisted laparoscopic approach by making small holes in the flank area or in the belly to remove that essentially dead kidney. When someone tells me that they have an atrophic left kidney, one of the questions I have is, how atrophic? How compromised is that kidney relative to function? If it's producing if it's doing maybe less than 20% of the overall filtration of the body, maybe you want to consider taking it out if it's causing symptoms. On the other hand, if it's not causing symptoms, you might want to consider just leaving it alone. So the third option, reconstructive surgery of the blocked ureter and attaching it to another part of the bladder. That may not be an easy feat. You see, anytime you've had radiation to the pelvic area, everything turns into essentially concrete. Normally, during surgery, we have nice surgical planes, meaning that the organs and the structures are separated by different fascial or covering layers of these organs. So during surgery, during dissection, we can clearly discern what is what to take out, what not to take out, what to touch, and what not to touch. After radiation, Same thing for cervical cancer radiation, same thing for prostate cancer radiation. Those normal tissue planes are utterly destroyed. There are no clear surgical planes. Finding the ureter may be challenging after radiation. So now you're thinking about unhooking the ureter, cut back to the normal part of the ureter, and then moving the bladder, which is near the area of radiation, and then fashioning the bladder to reconnect to the ureter that you already cut short. That's not going to be an easy operation. Also, if the kidney is not working well, there's not going to be much urine going down the reconstructed ureter. And when you don't have urine going down to the reconstructed ureter, that ureter is not going to stay open. Furthermore, prior radiation to that area is going to possibly compromise the blood flow going to the ureter. Your surgeon will have to be absolutely sure that there's good blood flow going to the part of the good ureter that he or she has dissected free from the scarred portion. And when you reconnect the ureter to the bladder, you got to make sure there's good blood flow, or else that connection is not going to stay open. It's going to fail. Then you end up with urine draining into the belly, or scarring, or some other complication because of compromised blood supply or decreased urine flow going down the ureter. So it's not so easy. And also, yeah, when the kidney is not working well, then reconstruction of the blocked ureter in attachment to the bladder, I don't know. I need to know how well that kidney is actually working. So another approach would be to leave it alone, right? The fourth option is to consider leaving it alone and do nothing if the kidney is not working at all. You could also consider, well, you can put it in a nephrostomy tube. And the next step I would consider is figuring out how much function is there in that left kidney while the tube is draining the kidney under ideal situations. So if the kidney function is still pretty good, then you want to consider salvaging it by providing adequate drainage to the bladder or some other way to drain that kidney, to keep the kidney function, to keep that kidney working, to filter out the bad stuff in your bloodstream. So again, you ask a question online, it raises more questions for me, and treatment will depend on those study results, on how bad that kidney is, how well it's draining, how little or how much function that is providing, and also your symptoms. If you're having no symptoms, then observation may be an option, especially when there's not much function in that kidney. But I also want to know, well, how much function is there? You didn't tell me about the renal function and how the percentage, the differential function. Usually when we do one of these functional studies, it'll tell us 20% in one kidney and then 80% in the other kidney, or some other reading, usually totaling 100%. I need to know that information. I need to know how you're doing, and also any other medical issues and any other medical conditions that may contribute to what is going on. If you already have compromised kidney function overall, obviously we want to save as many filtration units of the kidney or nephrons as much as possible. And if that's the case, then we want to do everything we can to save that kidney and not take out the kidney unless we absolutely need to, because we don't want to cause further kidney damage or renal failure. All right. So lots of questions. As usual, anytime you ask a medical question online, we never have the complete information. And that's why it is very difficult to give an adequate or safe or complete answer online. That's why you should never, ever listen to any sort of medical advice online unless that person is your treating physician. All right. As usual, any questions or answers, please leave them below. I would love to hear from you. Somebody said audio malfunction. Okay. Well, I'll have to check and see if there's any audio malfunction. All right. Have a good one. Take care. Bye-bye.